So, uh, so my message today will basically be based on the discussion of all of these. We have had a very extensive panel discussion. I'll just put in a few viewpoints of my own. So the first study is the PRO-based trial that touched upon the difficulties of screening using MRI as a screening tool in younger men. So we should understand that the PRO-based trial is not on MRI. The PRO-based trial is mainly about finding a protocol whereby we can use a PSA risk adapted approach to screening for men. What this trial showed us that while MRI can be widely used, we still need to have people who can properly interpret an MRI so that we don't go down that road where we are doing unnecessary biopsies or we are unnecessarily grading lesions as high risk when they are not. About the next study using a combination of PSMA PET CT and an MP MRI, the study has an interesting promise, but what is its applicability? How do we decide that we do not want to do a biopsy in the PIRADS 3 patients as was done in this study? We all know that a significant proportion of PIRADS 3 patients still harbor clinically significant prostate cancer. So what is the use of PSMA PET CT in this intermediate group? That is something which needs to be addressed if PSMA PET CT is to be used as a screening tool. The results align with the primary trial, but it is something that needs to be looked at because one of the arguments used in the paper is that in a lot of solid organ malignancies like kidneys, we are not doing anything. We are going basically on the imaging results. But we have to understand that prostate cancer is nearly not so fatal as other solid organ malignancies. And treatment of other solid organ malignancies, for example, you do a nephrectomy, your functional outcomes won't be bad. But if you do a bad prostatectomy, your functional outcomes are going to be very bad. So that is something that needs to be looked at. Now, this trial, this is something very close to my heart. I'll show you in the succeeding slides why. So this trial showed that transperineal with no antibiotics has no infectious complications, and transrectal with culture-specific antibiotics has similar rates. Transrectal route does require more work, and that is why transperineal is the way to go. That is the message given by this paper. And I heard a lot of arguments in favor of this. So what we have done is, I have named this as Trexit. So this is a network meta-analysis which I have done. It is under review in Lancet Oncology as we speak. So we have compared rectal cleansing followed by transrectal biopsy with transperineal biopsy, with transrectal biopsy after empirical antibiotics, and rectal culture-guided prophylactic antibiotics followed by transrectal biopsy. So this is the rankogram. In the rankogram, we did not find any significant difference. The only thing of significance we found was that the number of febrile episodes were less if we did a transperineal route. And the best, in fact, in terms of septic complications, was transrectal route after rectal cleansing. That, in our network meta-analysis, turned out to be the best. I can't reveal more because this is still under review and we are in the process of publishing it. But this is what the data showed us. FOXPRO trial, again, a very lengthy discussion on that. It's important to understand that even in a low-risk population, the HIFU didn't really lead to cancer control, didn't really protect from development of a de novo malignancy. So as Sir said, the primary use is to probably buy a few years of quality of life while you are avoiding more radical treatments, which will impair your quality of life. I've already spoken about this. Just to reiterate that it was probably that single surgeon experience in that entire series of patients which led to bad results for the surgery group, because a surgical audit carried out on the next 1,800 patients had an incontinence rate of less than 1%, maybe more than 1%, 25 out of 1,800 robotic prostatectomies. So that's all as a take-home message. Thank you. That's my hospital. Not my hospital, the where I work. Yeah.
Rahul, can I have a small clarification on this? So, the PACE-B is a practice-changing trial. And the point that you made about one surgeon giving the whole results is actually a very serious thing to consider. Now, why would you think that this has escaped further discussion? Has it really changed? Has it been published? Has it been, or was it just your audit that you were mentioning?
I'll tell you. So
because you are essentially negating the PACE-B trial.
Insinuating or
I mean, I know that such internationally published trials will have very strict quality control. So how can this escape that?
Sir, this center where this trial was conducted, that's the Crown Center.
Sir, have you published it?
So I'll tell you
because you are basically insinuating against somebody who is not here to defend himself.
Yes,
isn't
I'll tell
it?
you.
You're not allowing that person to defend his.
No, I'm not defending. I'll tell you what we found out.
Yeah.
So a surgical audit was done.
Yeah.
A surgical audit of all patients operated before 2015. Most of these patients who were operated before 2015 were the ones who were included in this PACE study. And these patients had an incontinence rate of almost 30% as defined by pad use at 6 months.
You have mentioned that. What I'm asking is that, did you publish your findings?
So we didn't publish the surgical audit.
So many surgeons around, don't you think that you were sending out a wrong message? The young surgeons were here.
Sir, I'm just pointing out that may be one of the causes why
you have not published it, right? You are making an allegation. You are basically putting an entire trial, which has been universally accepted, under a shadow of doubt without reasonable evidence.
Have discussions like this and create doubt. Will somebody think of doing an audit?
At this point of time, it's your opinion.
It is not an opinion.
There is no publication of that. Sir, there is no vetting of that mention that you mentioned.
Right? To talk only about published material.
I mean, if you're not discussing publication here, what are you doing here?
Sir, if we are to talk only about published material in conferences, all our presentations would be over in 5 minutes.
Not like that. When you discount a published trial, then you have to counter with another publication.
Sir, we have a right to criticize.
I have made my point, Dr. Rahul. I have made my point. What I'm trying to tell you is that you should not put allegations.
I am not putting any allegations at all, sir. It is important to understand that if somebody has been there who has seen what has gone wrong, then that person needs to be heard, and that viewpoint
please
may not be accepted.
Please conclude this. Then we have to go to the next session.
Yeah. Thank you, sir.
Dr. Vinita.
Thank you, organizers, for having me here. And we can see that we had a very volatile discussion right in the first panel discussion. So a very great start for the GU knowledge series. I'll make some comments, short comments about the presentations that were made. For the ProBase trial, my simple comment is that peer review is the simplest thing that can improve the accuracy of MRI reporting rather than any other fancy stuff which requires more resources. So probably peer review is the way to go. The presentation on PACE trial, we could see that almost all the surgeons jumped out of their seats. It made them a little uncomfortable. Regarding this comment regarding that one surgeon had more, rates of incontinence, I would say that it is rather a real world scenario. We all have different kind of competence rates and different complication rates. So I think that's a very real world scenario which cannot be ignored. It is very clear from the randomized trial that radiation did better than surgery in terms of urinary incontinence rates, as well as sexual complication rates, as well as the control of the disease is as good as surgery. So it should be considered undoubtedly for any patient who's coming to you. For the PGI paper, which was presented, where they talked about the accuracy of multiparametric MRI and PSMA PET scan and avoid biopsy, I would absolutely disagree with that, because biopsy gives us wealth of information. This wealth of information cannot be and should not be ignored. This is one of the sacrosanct for any cancer treatment, and I don't think it is prime time to do that. My last message is that we all have to follow the MTT in true spirit. And when I say MTT has to be democratic. Doing the MTT just for the sake of it. I heard some comments that I always refer to radiation oncologists. I always document it. Just referring to radiation oncologist is not enough. Especially don't refer the patients to radiation oncologist only on paper. Please ask each and every patient to take a written opinion from a radiation oncologist. Please don't try to explain the side effects and pros and cons of radiation therapy to the patient by a uro-oncologist. I would also urge that we all have to lower our personal biases and probably lower our hats of a radiation oncologist or urosurgical oncologist while taking these decisions, because it is certainly not surgery versus radiation therapy, but rather it is the patient who's fighting for his or her life, and we have to take a balanced decision. Please pay attention to my last statement here. This is a scientific meeting. I would request all the seniors, all colleagues here, especially the chairpersons who were chairing the first session, that we have to avoid all unnecessary loose comments. In the interest of the science, we all have to follow science carefully. Thank you so much.